Hello, everybody. This is Anurag Deb. I work in the IndiaAI mission in Ministry of Electronics and IT. Good afternoon. A warm welcome uh, to today's information webinar on the IndiaAI NCG Cancer AI and Technology Challenge or CATCH grant program. Cancer today represents one of the most complex public health challenges of our time, not only because of its clinical diversity, but also because of the systemic barriers in early detection, timely treatment, and equitable access. India carries over 10% of the world's cancer burden, yet our oncologist to patient ratios, diagnostic infrastructure, and follow up systems are often stretched thin. In parallel, we are living through a period where artificial intelligence is beginning to reshape the technology sectors, not only the technology sectors, but also the core human services, including healthcare. The question we face is not whether AI can play a role, but how we ensure that the role is meaningful, responsible, explainable, and scalable. This is where initiatives like Catch become crucial. By grounding AI innovations in the realities of Indian hospitals and patient systems, we aim to move from promise to practice and to address the most important gaps of AI technology in healthcare uh, through clinical validation, through trials, through most importantly, evidence generation, and thereafter real world integration. And today's session is about unpacking that vision, clarifying this program's objectives, and engaging with you all, the innovators, the clinicians, and the institutions who can actually turn this vision into reality. With that, let us begin our program. To deliver the keynote address, I now invite Mr. Rizwan Koita, the founder of the Koita Foundation and chair of NABH. He'll be speaking on enabling AI-driven health innovation for national impact and reflect on how AI can accelerate India's effort in building scalable and impactful solutions for public health. Over to you, Mr. Koita.
So first of all, good afternoon to everyone for joining today. We have quite an illustrious panel headed by Dr. Pramesh from Tata Memorial and the National Cancer Grid, and a very strong team of cancer specialists, as well as some very strong technology professionals on the call. So really excited to be on the call today. I'm going to make just very few opening remarks, and then I'll pass it back to you. So I think this is, at least in my mind, quite an important event, and the catch grant that we have between the National Cancer Grid and the India AI mission is, when we look back after a few years, I'm quite optimistic that the catch grant will become, one of the important milestones in the evolution of healthcare and the use of AI in healthcare in India. It's a unique partnership because the National Cancer Grid, as the premier a network of cancer hospitals across the country, has the best capabilities in cancer care in India. Some of the sharpest oncologists in the country are affiliated with NCG hospitals. And the India AI mission clearly is the dominant powerhouse that is driving the use of AI. Use of AI in healthcare is more complicated than in many other sectors. Anurag was mentioning briefly that there's lots of opportunity, but in reality, driving use of AI in cancer is very complicated, like it is with other areas of healthcare. And there is a very significant need to make sure that the areas that we define for innovation are well thought through. The solutions that get built are clinically aligned. There is enough and more care given to validation, to bias, and many other factors that become so important. And most importantly, several of these AI tools impact the care delivery ecosystem, and therefore they have to be tested and validated at a much higher level than perhaps in many other sectors. Yeah. So I do believe that the partnership between the National Cancer Grid and the India AI mission is extremely powerful, because it brings in the clinical expertise of the National Cancer Grid and the scale and the coverage of India AI. And to me, the success of this will not only benefit the growth of very strong companies, very strong startups, and use cases in AI for cancer, But I think the part that excites me even more, that if this is successful, then this type of collaboration between India AI Mission and the National Cancer Grid can become a template which can be expanded to many other areas of healthcare, right? So I think the benefit of doing this thing successfully is not only in cancer, but the implications could be quite a bit broader than that. And therefore, it makes me really excited there. I would like to take the moment to thank Mr. Abhishek Singh from the India AI Mission for his leadership in driving this partnership, and really look forward to collaborating closely with both these organizations and supporting what we can do from a foundation perspective. As we will see today, the National Cancer Grid is starting to do a lot of work in digital innovation. And the initiative with India AI Mission, in a sense, is one of the anchor initiatives that will become important for the National Cancer Grid and its digital efforts as well. Yeah. So look forward to hearing more today. And with that, I'm going to pass it back to you, Anurag, and look forward to a very interesting conversation in the rest of the webinar. Yeah. Back to you. Yeah.
Thank you, Mr. Rizwan, for that important framing. We will now move on to a panel discussion on AI in cancer from concept to clinic. This conversation will explore how AI can drive clinical transformation in oncology, from algorithm development to deployment and adoption in real hospitals. Our panelists will reflect on the technical maturity, data governance, and critical role of public health infrastructure like IndiaAI and the NCG.
Thank you very much. I'm very happy to be hosting this illustrious group of clinicians and technology leads, and also all the people who have joined in with so much enthusiasm on a working day to hear about the Catch Grant and NCG initiative to promote AI in cancer and cancer research. So let me start off. Welcome, everyone. So today's panel actually dives into how AI is reshaping cancer care. We want to take the bold ideas from research labs and take them to have impactful research in hospitals and probably implement them. So we have joined by leaders who have walked both clinical and policy paths and who know what it takes to turn promise into practice. And you have the opportunity to listen to them and also to ask questions. In the next 20 minutes, we will explore how AI can truly transform oncology, not just in theory, but in our reality of healthcare, which is in India most often messy, because it has challenges of multiple languages, multiple cultures, and we have to mix all those when we practice care in India. So from clinical validation and ethical data use to funding, mentorship, long-term sustainability, we will try to unpack what it takes to make AI work for patients, providers, and the healthcare system. So to answer your questions and to share their thoughts, we have Dr. Manju Sengar. You will know, most of you will know her. She is the common sense voice in oncology, especially in hemato-oncology and clinical trials. She blends deep academic rigor with commitment to accessible, value-based cancer care across India. And she works from Tata, Mumbai. Dr. Vishal Dio represents ICMR, National Institute of Digital Health and Data Science. He is a scientist there. The group spearheads India's digital health research agenda, bringing sharp insight into data science, policy, and ethical AI implementation. And finally, the person who doesn't need introduction, Dr. C.S. Pramesh. He's the director of NCG and leading this program. Dr. Pramesh champions collaborative cancer care. He also pushes us to drive national standards, and also recently has been pushing the entire oncology community to adopt technology for equity and system-wide transformation in healthcare. So having introduced all of you, let me just quickly go into the discussion. I'm not going into any basics of AI because we know the technology partners and the clinicians here are already knowledgeable about it, so that they are trying to apply for this Catch Grant. So there are some concerns when we speak about AI in healthcare and especially oncology. And majority of these concerns are about the ideas that we have, which probably are some tools. what stops us from getting these great AI ideas from becoming real implementation tools in hospitals? I would ask Dr. Manju, who will represent the clinical phase of things, Vishal, who will represent the technology side, and Dr. Pramesh, who will represent the administrative views on such things. So over to Manju first, and then we will take others' views on this.
Hey, thanks, Balu, and thanks everyone for this kind invitation to join on this panel. So if we talk with respect to the use of AI, and I'm going to limit this to the oncology setting, I think the most important, or probably the immediate application which comes in my mind, is looking at how we can assist the systems with respect to the healthcare delivery, how it's happening currently. So if we look at, we know that the number of healthcare workers, if we look at the number of cancer cases across the country, if we look at the denominator of those and look at how many healthcare workers are there to handle those cases, it clearly gives an idea that there is huge inefficiency in the system, and it's not in any near future we'll be able to bridge that gap and have a adequate number of healthcare professionals available to handle this much amount of cancer burden we have. So I think some of the tasks which are relatively simpler, which can be handled without requiring too much of validation effort, can easily be done using systems which where the AI is deployed. Now, whether this involves when the diagnosis is made, whether the counseling sessions which are there, the continuum of care, telling patients or helping patients how to do their medication management, how to do their symptom management, whether it's once they start therapy, the toxicities which come up, once they go back, the disease-related symptoms which come up, and of course, a very important area which is the palliative care delivery, where the AI can play a major role. So this is something which can happen relatively earlier. Then there are areas where we do need a good validated study, like how we require for any intervention which is deployed in oncology. We would need good studies, good clinical trials to look at whether those AI tools are good enough to be used in day-to-day clinic. So when I'm coming to that, it's largely in the area of diagnosis. It's largely in terms of designing what we call as individualized or the personalized treatment, looking at replacing some of the investigations which are done using the lab technology, whether we can integrate the other data which is available and get the similar information. So these are some of the areas which will take some time. But as of now, I think it's the task, assisting the healthcare workers, making systems more efficient, ensuring compliance treatment is something where I see that there is going to be an immediate application. Thank you. That's all from my side.
Yeah, thanks, Manju. So I just surmise what you say. You mentioned that AI can have a role in assessing the healthcare systems, enabling continuum of care, monitoring patients, enable clinical trials, and also you're also calling for clinical trials in AI and also personalization of care. That's what a clinician's view of AI in oncology is. Vishal, what do you think from the technology side and probably from the ICMR side? Where do you think it stands?
Yeah, definitely. I mean, I would start from where what Manju has said, that we should start looking at the smaller aspects where we can our chances of success is definitely high, risk is minimal. Because whenever we talk about AI, we start thinking more in terms of whether safety issues, ethical issues are at place or not. So maybe start somewhere where we are bridging the gaps, helping the healthcare workers, where definitely all the outcomes are going to be positive. There won't be any risk associated with the technology. But obviously, when we think about applications for more, for interventions which we want them to be integrated into the system, then we have to think more in terms of not just technical validation. So if we think about all the solutions which are there in the country, a lot of institutions say IITs, ISC Bangalore, private partners, startups, they have been developing such wonderful solutions, AI-based solutions, whether it is for screening, for cancer or for TB. But the problem is they are limited, mostly they are limited to technical validation. And what remains is both clinical validation and the implementation part of it, which is, I think, personally believe is the hardest part. And then that part of it is going to take time. We have to do much, bigger studies, conduct clinical trials, or maybe if we are looking for, community settings, then we may have to go for randomized cluster randomized trials and all. So those things are going to take time, but we should always start with something. For example, I'll just give you one example that suppose in a clinical setting, we simply use a device where or maybe for even doctors, where whatever the doctors is speaking is transcribed directly into the EHR system. Now that's a simple solution, but that has a lot of impact. That saves a lot of quality time for the caregivers. So those kind of solutions we should start looking at, some low cost solutions to start with, and some bigger solutions which have direct implication on patient health. They need to have a much larger life cycle. We have to go through a lot more rigorous clinical validation and evaluation before they can be integrated into the system. So that's my take. Thank you.
Thanks, Vishal. I think I'll highlight your first point that you said, where the whoever is trying for a cash grant should look for the chance of success, which has to be high impact and probably less risk when you start off. And that's where we would make a change in the initial period of this AI implementation in cancer care. And you also mentioned about an example. I think last week or early this week, NCG had actually demonstrated one ambient VMR solution. And I think that is one way AI will transform cancer care or even healthcare in the country as such. Sir, over to you. As an administrator, how excited are you to see this response of people coming in such high numbers to attend this webinar and to look forward to apply for this cash grant? And also, second part of the question is, how do you see AI evolving in cancer care?
Thanks, Balu, for moderating this and bringing this out. So I think the very reason we launched the NCG India AI Catch Grant was the fact that we truly believe that digital health and digital tools can transform the way we treat patients with any kind of illness, or to take it one step further, even to manage people without illness, to make sure that we are able to prevent several illnesses in their lives. So we truly believe that many of the advances that have happened in high-income countries are advances which we can leverage digital tools to leapfrog in a much shorter time frame. Having said that, I think we need to remind ourselves of some of the reasons why digital health and tools are not being adopted as readily as they should by both individual healthcare providers as well as hospitals. And one of the reasons I feel is that very often there are solutions which are out looking for a problem to solve rather than the other way around. It truly needs to be driven by on-the-ground problems that patients, clinicians, and people face with relation to their health, and then look for a solution to that rather than come up with a solution and say, hey, can we look for a couple of problems which this solution can solve for? And often this is because the way technology develops and the way innovation develops is in silos compared to what the clinical needs on the ground are. So I think one of the strong reasons I feel initiatives like the Catch Grant should become more popular, not just in cancer. This is a test case, as Rizwan said. We hope that this will expand to other areas as well, is the fact that we are able to get clinicians, patients, caregivers, and startups and tech companies working on the same problem, coming up with some kind of a hackathon, which will then solve for problems that genuinely need to be solved. So we need to move away from working in silos, the tech folks finding up solutions for problems that are imagined, and the clinicians and the patients out with problems without knowing who to partner with in the tech space. So I think that's the bridge that we are trying to cross. And we hope that the kind of support that we are able to give through this is not limited only to the grant money itself, but more importantly, the expertise of the clinicians and the exposure to patients and patient groups that the National Cancer Grid currently has. Thank you.
Thank you, sir. So after the first round of answers, I would just surmise that we, as participants who are applying for the grant, we know from the clinician, Dr. Manju, where all we could probably apply it. And most importantly, she had asked us to look at continuum of care and personalization. And from the technology side, Vishal said the most impactful implementation would be where the risk is less and the chance of success is high. So you should be looking at driving your protocol in that direction. And I would like to highlight this word. The most importantly from Dr. C.S. Pramesh is that we are not looking at solutions which are looking for problems to solve, but the other way. So please look at the relevant problems in your clinic and bring it forward and bring technology-based AI solutions to solve those real problems. So we will now go a little fast with our questions and discussions. The panelists will get only one chance to answer in a minute. So first and foremost, from the clinician, from the administrator, and from the data scientist, as well as the policy person, I want to know, what do you feel as the single most barrier for a technology to come to a clinic, especially AI? Manju, first on you. From the clinician's viewpoint.
Yeah, I think the biggest problem is, as Dr. Pramesh mentioned, that many of the things are started from the technical side without having an adequate clinical input. And that's where the challenge comes in, that, you have solution ready, but that's not really what the clinician requires. So I think the first and foremost thing is the bidirectional talk, which is important. Understanding the problem statement and then developing, and it has to be a co-development, which is important. Because you can bring up a solution, but if it's not something which is user-friendly, it may look very user-friendly to the technical person who has developed it. But if it is not user-friendly for the clinician, it's not going to go forward. So I think a discussion and a co-creation is something which is very important. And the second part is, of course, the resources and time. Everything requires validation. There is going to be an iteration on that. So the time which is required both at the clinical end and the technical end, and the patients which need to be there, that you've brought in something which is a fancy toy, but if it's not really helpful in the clinic, we are not going to use it.
Great, Manju. I think you echoed the same thing, solutions looking for problems than problems being solved. Vishal, purely from a technologist, from a person who is actually doing a startup who wants to bring in a solution, what do you think is a major barrier? Everyone will say doctors. I want a different answer.
So biggest challenge is data.
Okay.
So the lack of a comprehensive health data ecosystem. So Rizwan will agree with me. So we had a meeting of our scientific advisory committee recently, and all we talked about was how ICMR is going to help solve this issue, because startups need data to actually go ahead with their solutions. So they are training their models, but based on very small sample, they are not representative samples. And then when we take those solutions to ground, we see that their performance, obviously, they don't perform as well as they were trained. So data is something we need to work with. We need to start changing the habit of not sharing data, so that one aspect. Second is there has to be a push from the government agencies and agencies like ICMR. So our institute is actually starting to work more on data rather than just developing solutions. So we are working towards finding out how we can establish federated data models and data sharing models within the country. We are talking with states. If that is something which can be accomplished, then we can have a well-established system. A system like AI Kosh can actually then work, and where all the innovators can use that platform to train their model. So that is, I think, one of the biggest challenges. And the second
good.
one is you
Yeah,
also, I
sorry.
mean, the frameworks for data sharing, that has to be clear and concise. That should not be, scary for everyone. So that is something we have already started working on. So yeah, I'll stop at this.
Thanks, Vishal. Maybe let me just sidestep and ask Rizwan Koita whether you've been doing some good work on this front, at least in oncology with NCG. Can you just share something to the rest of the team if they are unaware of what has been happening? Quick update on what is happening on making data standards as well as making data shareable.
Sure, sure. And something that Santosh will be talking about soon as well. Our foundation has been working with the National Cancer Grid for almost 3 years now. And the first initiative that we undertook, and we've spent a lot of time on that, is standardizing what electronic medical record needs to have for appropriate cancer care. And as we know, the overall penetration of electronic medical records in India is fairly low. And even in cancer, it is low. And what we found is that for products to be used effectively in cancer, there were lots of important features and functionalities that a cancer specialist need in an electronic medical record, which were not present in many of the Indian products. So we've spent a significant amount of time working with EMR companies in India and really helping them scale up their capabilities. A part of the exercise is not just helping the EMRs get better, but also start to define common data elements which can then become interoperable. So interoperability between EMRs, specifically in the context of cancer, has been another initiative that we have been at it for the last 1.5 years, and happy to report that now we do have a framework that has been successfully tested between multiple EMR companies, where digital information can be moved from EMR A to EMR B using a certain set of common standards. Lastly, and then I'll pass it back to you, is a conversation that we now having with ICMR and its efforts on the cancer registry. It's something that ICMR has been doing for the longest time. Almost all the work that ICMR does in curating cancer registries is based on a fairly manual and therefore fairly time intensive process, which it may take years before data from the field actually gets into the cancer registry. Now, if India is going to transform and we are going to have electronic medical records in cancer hospitals, then it is worthwhile to come up with common definitions of how that data can be moved into a National Cancer Registry electronically. And if we are able to successfully pull it off, then India will start to have a near real-time data when, based on certain life events of a patient, when data has to move to a cancer registry, we can start to push it through, right? So I think lots of very exciting things happening. Unfortunately, everything in healthcare takes time. So, this will also take time. But I think we do have a great start. And what we are trying to do now at the National Cancer Grid with the catch and the focus on AI is really building on that foundation that has been thought through over the last couple of years and taking that forward. Yeah. So with that, I'm going to pass it back to you, Dr. Balu.
Sure. Thank you. Thank you for that insights. Sir, I'll just change direction and just ask you, what prompted NCG to actually push for this grant?
It was primarily for many of the reasons that have just been mentioned, Balu, the fact that we don't have the end users and the startups and the tech folks working on problems together, identifying, prioritizing areas for research, areas for building solutions. And we felt that if we mandate that anyone who wants the grant needs to work as a team with clinicians, potentially patients, patient groups, and tech startups, that would be a way of trying to actually identify the pressing problems that we have today and to try and find solutions for them. So typically when most people look at AI, at least in the cancer space, if you were to ask a few startups what they want to do or tech researchers what they want to do, 9 out of 10 people will either say something like, I'll look at tens of thousands of pathology images, radiology images, and try and figure out a way how we can diagnose or triage patients based on what the AI tells us about the imaging, either by way of pathology or radiology. Or the others would say, I'll come up with this new extremely high-tech screening tool, which can then replace mammography or HPV DNA testing for cancer screening. But what we fail to understand is that just by the technological innovation involved in that, as Vishal mentioned earlier, and I think someone else also mentioned earlier, without clinical validation, it's actually worthless. And that's something that we need to think about. And secondly, the fact that these are extremely difficult problems to solve, especially if you want to scale up. It's the easiest thing to do is to find 10,000 images at Tata Memorial Hospital, find X-rays which have been diagnosed as TB and which have been diagnosed as lung cancer, and say, I've got this new algorithm that can differentiate the two. But if you're not able to replicate that in another clinical situation, the entire solution is of no use. I just want to remind this group, let's even not talk about AI, even something as basic as sensors. We knew how badly they failed during the COVID pandemic. When they put the same pulse oximeter onto a Caucasian and looked at their oxygen saturation, and this were all sensor based, and they put the same thing in an African American, the validation was no longer holding true. So let's forget about AI. Even becoming to something as basic as sensors need to be validated in an unbiased population before they become ready for prime time. And often we forget this in the development process.
Thank you, sir. So now just zeroing in on the grant, we have, through the NCG Catch grant, we have the clinician who's providing a problem to solve, the technology group which is offering the solution to solve, the hospital environment where you are trying to implement it, and there is NCG and MeitY who's offering the money. What else do we need beyond this? Is that enough? Maybe Rizwan is finding, so I'll ask him.
I think we just need creativity and entrepreneurial energy to put all of that together. And
Okay.
and even in many other areas, like we say, data is available. Even to make data available needs entrepreneurial energy, because while in principle data is available, there is a lot of pushing and shoving required in the field for data to become available. It's almost got to a point that to run advanced algorithms is actually just a click of a button. Everything else is a struggle, so the most complicated part from a technology perspective is literally a click of a button if only all the other pieces fell into place. So arranging for compute, arranging for data, all of that is arranging for doctors to validate your solution, getting to engage with patients who are going to validate your solution. That is all the hard part. Applying the latest tools and the latest algorithms and using the latest code base that ChatGPT launched last week, very easy.
So I'm just marking those words. I'm hearing it for the first time, entrepreneurial energy. So probably we clinicians have to also look forward to adopting that fact. What do you think, Vishal? An answer to that question?
I think what Rizwan has said makes a lot of sense. The hardest part is not the technology part. That is there. We have lots of expertise in that part. But bringing everything together. And then comes the same question which Pramesh actually talked about beautifully. That first of all, the first thing is that the problem statement has to come from the clinical aspect. And then technological partner, they have to understand the problem before they think about developing solutions. And I'll just give you one very small example, which I was just thinking about. So I was reading some papers on predicting CKD, chronic kidney diseases. And these papers were published in highly reputed technology journals, not in medical journals, IEEE journals. And what they had shown excellent accuracy, excellent sensitivity, specificity. But when I looked at the variables they have used, one of the variables they used was EGFR. Now, EGFR, if it is known, there is no need to predict CKD. And I was so amazed that this is the lacuna when the papers are not being screened by medical persona. So only the technical part has been, reviewed. So suppose that happens in developing a solution which is actually being integrated in the system. So that is something very important which we have to consider. So I think Catch Grant is a very beautiful example of how it should be done. NCG is a champion of collaboration, and NCG is again showing the way how the medical and the technology partnership should be done and collaboration should be done.
Thank you, Vishal. So I'll just get back to the grant and the same question where we have a triangle of this would be my last question, and then probably I will ask some of the panelists or other members to ask some questions. So when we have this triangle where patient is at the center, there is a healthcare person with the problem, there is a technology partner with the solution, and MeitY and NCG with all the money. But I am still somebody who is starting off as a group. Okay, and this is we are actually quickly bringing everyone together. We don't know how it will sustain. We don't know what is entrepreneurial energy. So how is NCG going to help us beyond giving us the money? Maybe, sir, you should tell us, is there any mentoring that you would offer?
So thanks for asking me that very easy question, Balu. I think one of the secret ingredients that you possibly need, along with whatever we are trying to put together. So there's 3 or 4 aspects that you mentioned just now. I think there's one additional secret ingredient that's required, and that's endurance and stamina from the people who are involved in this grant. It's very easy to get enthusiastic about a single idea, spend a week writing it up, subbing it, getting the excitement of the grant being approved. But it takes a lot of stamina and endurance from everyone who's concerned in this triumvirate to make sure that this goes beyond just a protocol that's written, something that actually sees the light of the day. And this is where I think the biggest challenge is going to be. We'll have clinicians whose enthusiasm will slowly go down, given the fact that there were 100 patients in the clinic, the time that they need to spend with the technology partner to make sure that the development of the solution happens at the rate at which it should. And then finally, when we review these projects at the end of a fixed period of time, we need to be showing some progress for it to be to continue to be funded. So I think for us to get the stamina to make sure that the partners in this enterprise have the endurance, they know what they're getting themselves in for, they find the protected time to be able to devote to these developing these kind of solutions is to me a key ingredient. From our side, we'll be happy to matchmake. We see our role here primarily to matchmake between people who have ideas, technology partners who have the capabilities, and we provide the gap funding for that.
Thanks for this interesting panel discussion and webinar. EkaCare is a EMR scribe and a startup that solves for doctors' documentation needs. And I agree with what Rizwanji mentioned, that it needs an entrepreneurial energy to solve for. But just to add, I'm an entrepreneur myself. For health, it needs an resilient entrepreneurial energy to solve for the deep use cases, because it takes a little bit of time. So my question is more around, is there a time frame, or how do you see this getting successful, and the deployment of the solution as you pair up the startups and the solution making companies with the any sort of hospitals and clinics? So is there a time duration to it, so to say?
I think Vikalp, we have all the things set up and the answers are also ready. I think Santosh will be taking you through the details of the grant, and your answer would be clearly mentioned there. Maybe Santosh, do you want to proceed with that so that we can then match the questions?
Sure. In fact,
that
a lot of
might
questions which are
regarding the
mentioned
grant
here will get answered. But let me thank all the panel members first: Dr. Pramesh, Dr. Manju, Dr. Balu, Rizwan sir, as well as others who contributed and gave us the good enough information about what this overall grant means and why we need it, and how the entrepreneurial energy is going to help us to keep us going. So I'll quickly share my screen, and along with question and answer, I just wanted to cover a brief summary about what we do as NCG KCDO Center and what are the initiatives we have. And then from there, I will cover the question and answers as well. So if you look at Koita Center for Digital Oncology, it's a a joint venture between National Cancer Grid and a Koita Foundation. It started almost August 2022, and the objective is to make sure that NCG and NCG hospitals adopt digital tools, drive collaboration, and digital transformation happens at a ground level. KCDO focuses on three key areas: support NCG hospitals, drive common initiatives, and do research. So, one of the example, as Rizwan mentioned, the EMR adoption is something very key initiative, because with EMR, we will have all the patient information in a digital format. And once we have data available in a digital format, a lot of other initiatives can actually stand on shoulder of EMR data. These are some of the initiatives we are focusing as a part of NCG KCDO. And at the bottom, if you look at the digital foundation and capacity building, that's a major building block we want to consider. And some of the initiatives are already in progress, such as Oncology EMR we spoke about. Oncology KPIs, these are some of the standard KPIs defined, where the administrative as well as metrics about clinical quality can be shared. DHFC is another a key initiative. That's where a digital health foundation course. It's a tailored course for oncology specialists to understand the digital health as well as the digital workflows. And this is developed in partnership with Koita Foundation and Maharashtra University of Health Science. VTB library, again, a lot of curated videos are available in form of metadata indexed, so that it can be searched and the definition and the details can be quickly found. The DHSL is Digital Health Solution Library. This is a curated library which we looked at each solution from the relevance of the oncology care, as well as the relevance from the existence of the solution, as well as the implementation of the solution, at least at 2 to 3 places. With that, we have today more than 80 plus solutions, where hospitals can log in and look at these solutions, and whichever are applicable to them, they can implement them. If they need any support, we can very well help hospitals in that journey as well. In terms of access and quality, again, that's another important layer. That's where we are working on synoptic reporting and public patient education initiatives as well. And at the top, we have this innovation and research. That's where AI, speech to text, oncology data bank, and innovation framework. These are some of the initiatives we have started, and this catch grant is one of the initiatives. Moving on to next slide, these are the high level use case summaries we are looking at: screening, diagnostic, clinical treatment, patient engagement, research, operational efficiencies, and data curation. Now, in these categories, if you guys are planning to create a solution, it would be more relevant to what we are looking at under catch grant. And the details are available with the document as well, which is available on IndiaAI website. But let me get into some of the questions which will get answered with this slide. So who is eligible? Any startup, MSMEs, private limited companies, for that matter, even public sector entities and autonomous bodies, academic institutes, research institutes, non-governmental, civil society organizations, hospitals. These are all eligible entities. And remember, as Dr. Pramesh mentioned, it's a joint application. So we treat a clinical lead and a technical lead. Clinical lead is going to be a hospital who have a problem. Technical lead is someone who has a solution or is willing to come up with a solution for the problem what clinical lead is facing. Ineligible entities, unregistered team or individuals will not able to apply. Companies which are not registered under Indian law will not able to apply. I got a lot of questions on email saying that, hey, I have certain companies which are working in India, but they are registered in other countries, but they are helping hospitals in India. unfortunately, those will not able to apply as well. Any entity which has been barred by central government or a state government or statutory authority or a public sector undertaking from participating in any project where the bar is still effect will not able to apply. Any entity which has failed to perform any agreement with a public authority or evident by the panelist or the judicial pronouncement. So those entities will not able to apply for this grant. Now, at a very high level, what is this grant is all about? So funding amount is up to 50 lakh. Again, it would be approved in two tranches. The first tranche is of 25 lakh, another one is 25 lakh. The first tranche itself is of 6 to 9 months, where uh, combined partners have to come up with the project plan of milestones, and those would be reviewed. On the meeting the milestone for the first tranche, the second tranche would start, which would be another subsequent 6 to 9 months. And for that, the second tranche amount, which is about 25 lakh, would be given to the applicants. Remember that whichever eligible solution where India AI team thinks that it is a potential solution for scale up, will get a 1 crore scale up grant as well. Now, what are the funding expectations? Grant designed to accelerate AI innovation in oncology care. There is no obligation for sharing the IP. However, tech lead is expected to have long-term contract with participating clinical lead with preferential rate. Now, there were a few questions on this statement as well. So I want to clarify here. When it comes to clinical lead and a tech lead, they are working together. If the solution is developed by accessing the data from hospital or a clinical lead, then in that case, the clinical lead should have a preferential rate in terms of implementing that solution in that hospital. So for that partner alone, there will be preferential rate as well as the waiver of license fees if applicable. And then of course, with the other hospital, they can demo and then they are free to have their license fee applicable to other hospitals. What is duration overall? So 6 to 9 months for the first tranche, subsequently 6 to 9 months for another tranche. So it's about 12 to 18 months is what we are looking at. We got some of the questions where multiple applications can be are allowed or not. So yes, if you're going to work with multiple partners or with one partner, you have multiple problems on which you're going to develop solutions. In that category also, you can have multiple applications, which is allowed. Budget heads restriction, full-time employee organization cannot be paid salary, but keep your budget up to 10%. IP rights, again, IP rights will belong to the tech partner and the solution partner. They don't have to share that with NCG or IndiaAI. What is expected is the data which would be used in anonymized format, that can be then given back to AI coach, so that it can be used by open source. It can be used as an open source resources by other organization to build on top of it. That's the only expectation from NCG and IndiaAI. If you look at the proposal timeline, no, sorry, this is a document form itself, how you apply. So there are about 7 sections in a form. The first section covers team information. Second is a project proposal, along with, of course, technology readiness level. Third is a proposed solution, what the solution area, core AI, technology used, alignment with IndiaAI and NCG, and some of the use cases we just mentioned, how it would be aligned and how you're thinking about solving the bigger problem. Evidence of readiness, deployment details, outcome, current partnership. If you have any demo link, that would add a weightage. Implementation plan, of course, as we spoke about tranche 1 and tranche 2. So 2 tranches, milestones, what you define and how it would be assessed. Timeline and risk mitigation. If you perceive any risk in terms of achieving milestones, then what are your plans to mitigate that risk as well? Then budget and sustainability plan. So how you're going to split the budget which you will get, any key resource profiles, so this is very important. We want the partners, whoever will be nominated as a key team members, we want that continuation of that team to the end of this program. So key resource profile is something we are expecting from a tech partner as well as uh, you know uh, hospitals, so that these key resources will continue throughout the journey. Then again, of course, supporting documents such as your legal registration, endorsement, any white paper or ethics clearance. Now, following is the link for the application form itself, where you will see these sections and you will be able to submit all the details. Now, only way to apply for this is through this application link. We will not take any applications on email. There were certain questions on those lines as well. So wanted to clarify on that. This is the overall timeline. We already launched a grant on 2nd August 2025. Last date of submission is going to be 2nd September 2025. Screening and completeness check will be over from our side by September 13. Announcement. After that, there would be, probably a presentation and a discussion will happen with the selected application. Announcement of grantee would happen towards November 22, 2025. We'll give enough time for IEC approval. What needs to happen here is the technical lead and the clinical lead need to go back to IEC, and whatever solution they are going to implement, they have to take the IEC approval. And again, health being a state subject, the hospital where the hospital is located, the state laws of that hospital, or the regulatory laws of that state would be applicable, as well as the ethical committee regulations. Only the approved projects would get the grant. So there is good enough time. If you want to convince IEC committee, as well as if there is any deviation required, then there can be a 1 or 2 time back and forth, so that you get the approval. By February 28, we are expecting approval to be in place, and once we get all the details, then the grant distribution will happen from March 1st onward. These are the links where you can find more details. There are 3 emails listed here. Feel free to reach out to us in case you have any questions. And now I will take you guys through question and answers, the FAQ document we have put together.
Thank you, Santosh. Just a quick sort of announcement for all of the participants is that we have put out a survey link, a poll link for the participants to fill out. Please do take some time to fill them out, and it'll help us, sort of help you better during the process of the grant.
Sure. So Anurag, while you're talking about this, I'm just sharing the FAQ document, and once you're done with your announcement, I'll start walking through the FAQ document.
Yeah. Again, thank you, Mr. Patil, with the objectives and the processes now clear. We will now open the floor to questions from our attendees. There are 2 ways we can go about it. One is that we already have a lot of questions in the Q&A box. If there are some specific questions that specific panelists would like to answer, feel free to sort of take the floor and start answering them. And also we would ask the sort of participants to raise their hands, and we can individually then start sort of taking some of the questions up. Thank you so much. And then we'll move towards closing remarks.
Anurag, I've noted a few questions to answer live from the Q&A that is posted. So one of the questions that was asked is Ayush-based solution, which can be partnered with the technology under the scope of the grant. I think Dr. Pramesh is here.
Yeah. So I think so long as the intervention that is being studied is evidence-based and proven in other clinical trials to be effective, all we are looking for is evidence-based interventions, regardless of the type of medicine.
Thank you so much, Dr. Pramesh. Mohit Soni, you have your hand raised. You can ask your question, please.
Hi, just a brief introduction. So I'm based out of Jaipur, and we are world record holding CT and MRI scan specialists. and have been working in cancer now for almost 18 plus years.
Just a,
And-
just a second. So here, let's not let's get straight to the question. For everybody who's asking questions,
So one of
in the
the
interest of time,
So
please.
I'll just come straight to the question. So Manju ma'am and Pramesh sir have already highlighted, and I believe they're also working with Professor Amit Sethi, that there are two challenges. One is getting the data, but there's a deeper challenge in validating the data. For example, in radiology, CT, MRI, we can predict when there is a tumor at an early stage of detection. But unless it is biopsy and confirmed, it is very difficult to do it. So in addition to the grant, are we also able to get some kind of a mechanism to validate the data?
So I think
Or access to something of that sort? Very well said, sir. Thank you for that clarification.
Thank you, Mr. Mohit. Mr. Ajit, can you please state your question?
Yeah, my question is straight to the guiding people. So, what are the adoption challenges if we develop this solution? What exactly they envisage as a challenge in adoption of such solution, and what are their expectations from this challenge?
Okay, I think I'll quickly take up that question, Mr. Ajit. First of all, the solution has to be at a TRL 5 level, which means it has already been developed to some extent. Uh, and then in terms of challenges of adoption, it depends on the kind of problem that you're addressing. And uh, I think that sort of a pathway to scale and adoption has to be addressed very specifically to your own, sort of nature of solution. Is there anybody else who wants to add to that?
I'd just like to add that the solutions that you're going to look at will be evaluated based on how broad the likely adoption and implementation are likely to be. So if you take a problem which is common to multiple people rather than an extremely niche area which is likely to benefit a small group, that has a higher chance of getting funding.
Anurag, I want to add a few questions which I read through the Q&A, and a few recurring questions I want to add so that that is clarified here. One is, can we go below TRL 5? TRL is technology readiness level, and the grant calls for TRL 5 and above technologies to be partnered with healthcare people. So there are questions on whether we can be applying at a level lower.
I think during the design of the grant, we ourselves struggled with this question about whether we keep it at TRL 4 or TRL 5. What I would suggest everybody who is also applying at TRL 5 or below that to honestly report what TRL level you are at. And depending on the cohort of application that we see, we will able to take a call if we can go lower than that or not. But meanwhile, I would encourage everybody to apply nevertheless, even if you are confused whether you are at TRL 4 or 5. If you are, but of course, if it is TRL 1, 2, 3, I think that would be too early for us for this grant to sort of fund you. Thank you.
That's a great clarity in that answer. Anurag, two more questions which I picked up. One is a call for, do you have a framework from question to implementation when it comes to AI technology in healthcare? And similarly, another question is on, does the grant support a framework for setting up federated learning solutions in India? So one is calling for, is there a framework that NCG can actually probably develop for people to come together from question to implementation? Probably if it is not existing, that's a call for NCG to lead that. Second one is, we need data, good quality data to be stored at various centers. Whether can we have a framework and support for developing federated learning solutions? I think any of the panelists can take up the answers to this.
Yeah, I think Rizwan has raised hand. So
Yeah, I can take that. So number one, the whole area of AI and healthcare is very new. So I think it'd be premature for any organization to say that we have a well-defined framework. In fact, what I would hope is, imagine there are several organizations that become successful through the catch grant process. We could then start to look at the different approaches that they have taken and start to come up with different methodologies for achieving that objective. And there may not be one framework, there could be a multiplicity of different ways of doing that. So I'm hoping that that becomes actually an end result of something like this. And secondly, the notion of federated data sets and all, when you say it, it sounds like, okay, this is a way to do it, but it's all very new. It's all very new, right? So for us or anybody on the call to say that, yes, this is an approach that is going to be possible, and yes, NCG will support it, etc. I think each a proposal will probably need to be looked at in the context of what is possible. Now, I don't think either Dr. Pramesh or anybody on the call has set an expectation which says, you give us your problem, we will get you the data. I don't think it is like that, right? So I think the primary responsibility of finding data sources, collection, will continue to be that of the recipient of the grant. Okay. Can NCG kind of support a little bit? The answer is yes. But it certainly cannot become, Dr. Pramesh, you may want to add on to what I'm saying. It is not like, oh, I have got a problem and obviously I need data, so I'm going to apply for the grant and then NCG is going to make that data available. I don't think that expectation can be met by NCG, because NCG at the end of the day, it's an association or an affiliation of a network of cancer hospitals, and the challenge of whether you want to go to a certain hospital and solve for it is a local challenge, right? We can influence it to some extent, but I don't think I don't think anyone can take the responsibility of organizing that. Dr. Pramesh, you want to add to my comment on data collection and the role of NCG?
No, I think you summarized it very well. I really have nothing else to
add. Thank you, Rizwan. Thank you. Just one quick addition is that the diversity of data sets that you might be needing may not be even sort of confined to your own locality. So it would be very sort of challenging for say IndiaAI or NCG to come in and provide the data for you. Mr. Dilip, can you go ahead and ask your question, please?
Yeah, thank you. First, thank you for taking time to providing this insight. My question is related to, you have 6 streams at least. I'm leaving the last one. The 6, for any provider to be successful from end-to-end life cycle, all 6 streams at a higher level hospital need to be implemented. Here you're looking at individual solutions in each of these streams, but the success will actually come from putting that all together and putting that in a very effective way where the information flows, where the technology flows seamlessly, and the patient and also the doctor have seamless experience. Has any thought gone into the end-to-end process, how to make that successful?
So let me interpret the question. When you say 6 different, you're talking about the 6 categories of use cases we have listed here. Is that what you're saying, or you're saying?
That's right. I see Mr. Rizwan smiling. So
I'm smiling because when we do Catch 4.0, at that time, hopefully this could be a good objective of Catch 4.0.
I was about to come to that. See, the idea is to look at one problem, as Dr. Pramesh mentioned. If it is going to impact a larger, population to get benefited, then that's a solution we should go for. If you look at end to end, probably as an industry, or as a at least in healthcare, we are not there yet where we will have end to end solution with AI enabled. As Rizwan mentioned, maybe a few years down the line we might be there where we will have end-to-end solution where we will say, okay, complete AI of this workflow, and would apply for it. But as on today, I believe you need to
Santosh, I would like to come in and give a clinical answer to it. So as a clinician who's been trying to implement technology and AI in healthcare, now if you are looking at end-to-end solutions, now it is going to be completely disruptive to our current healthcare workflow, and adoption will suffer. So smaller solutions, and later few years down the line, them coming together would be something that would work for us. As clinicians, I would see that is.
Right.
The question is not on one end-to-end solution. It's more an integration of all these individual solutions coming together. But anyway, thank you.
Anurag, you're muted.
Sorry. Thank you, Dilip. And I think panel, we can take 2-3 more questions. And is that okay?
Yeah.
Sure. Mr. Arjit Agarwal, you have your hand raised. Can you please ask your question? Okay, Dr. Suresh Kulkarni, can you go ahead, please?
Are they allowed to unmute themselves, or is that the problem that they're facing?
No, they are allowed to unmute it themselves. But let me try to unmute them and see if.
Hi, Anurag. This is Arjit. So I wasn't able to unmute myself initially, so that's why I didn't respond. So I'll directly jump into the question. My question is, in the application, you have also requested to provide the proofs of the past deployments or the past pilots done. So my question has two parts. One is, what constitute the proofs? What kind of a proofs do you need while filling the application? And second part is whether these proofs or past deployments are only related to the specific AI solution which we want to do the pilot for, or it is related to any other similar solution or any other broader solution as well, which we can provide proof for.
I think that's a good question, Arjit. The way we are looking at proof is one. If you have done some deployments with a hospital or with any government institution, you might have a work order or a contract or some sort of paper that you have published out of it. All of this will constitute as proof. And in terms of whether or not you are allowed to have a solution which is differentiated from the past deployment that you have, I think it has to be of the solution that is in concern, the solution that you're applying for. But in case it is a solution which falls under umbrella of AI solutions, and it's in the pipeline of the solution, then probably it is okay for you to show the past deployment regarding that. I can give you examples. For example, if somebody is developing a voice tool which is able to record or the conversations between the doctor and the patient, and sort of directly populate the EMR. Maybe you have done it for a TB setting, but you have not done it for an oncology setting. But you are willing to do that for the oncology setting. In that case, it's okay to sort of provide that past deployment. But if it is completely unrelated, then it will not be okay. And if any of the
Wonderful. You answered, Anurag. Thank you so much for your answer. Thank you.
I think Dr. Suresh, Anurag, can you unmute Dr. Suresh, please?
Yeah, I have unmuted. Dr. Suresh, I've asked to unmute a couple of times. Are you able to speak, not speak? Okay, I think Balaji, if you want to go ahead meanwhile.
Can you all hear me?
Yeah, we can hear you, yes.
Great. Hi. Thanks for highlighting this great initiative. I've collaborated with Dr. Suresh Kulkarni and Dr. Pramesh. How are you all both? I'm an outlier, born and brought up in Bombay, but I'm an imaging scientist here in the United Kingdom at University College London. I'm an imaging scientist, inventor, entrepreneur, create a lot of AI-based radiomics software which has been deployed in India. Is there any way, I know I'm not an Indian entity at this point, but is there any way I could collaborate in any form or shape, or it is a total no? I just wanted to get the panel's insight.
And I think, Balaji, if the entity has at least a 51% registration in India, or you have an Indian entity registered, separately from your company, then it will be possible. But if you are completely registered outside of India, not falling under any Indian law, it will not be possible, unfortunately.
What about academic collaborations from a University College London hat? Is there any possibility?
If you have an Indian partner here, then it might be a possibility. But essentially, you can be a part of their team, but they will have to lead the proposal. There'll be no UCL.
No, absolutely. So I do collaborate with TMH, Tata Memorial Hospital, and other institutions as well in the past, and some of the technologies that I've created have been deployed in India at premier institutes. So I'll be delighted in any form or shape that if I can participate and collaborate, that'll be great.
Yeah, essentially, the lead has to be an Indian institution. If you're collaborating,
that goes without saying. That goes without saying.
Thank you, Balaji. Afrin, can you go ahead and ask your question?
Yes. Good evening, everyone, and thank you for this opportunity. I just had a small question that if the AI solution is already validated and it has approval, CDSU approval, so do we consider it that we repartner with the hospital and then apply, or we can apply as a startup separately?
So at
That's
least, a clinical partner and a technology partner has to come together to apply. Now, if you don't have a clinical partner at the moment, we can look at NCG group of hospitals and who are willing to implement solutions, but you have to work with clinical partner to do a joint application.
Understood. Thank you very much.
Just another heads up for every applicant. In case, I mean, the panel, the evaluation committee would be looking at your application, will have the ability to determine whether or not, you can be actually, NCG will have the ability to determine whether or not you need, to go through a clinical trial. And if you have very strong evidence already in place, you can directly also avail this scale-up grant, by the way, just for everybody's information. Our panel, are we going to take any more questions, or do we wrap it up? Dr. Suesh, are you able to speak now?
No, I think it's a hand raised by mistake. I just checked with him. He's not able to do it.
So I wish to read out certain comments, which probably is probably worth perusing over it. There is from Monica Malik. It would be great if this forum could help to organize and pool individual efforts with working towards a particular solution, to collaborate towards comprehensive and sustainable solutions and reduce duplication and multiplication of efforts. So I just want to highlight this point of duplication and multiplication of efforts. Probably if two people are working on the same solution, does NCG have a way to fund them both, or fund them together, or bring them together? What would be the answer?
In an ideal world, if they're able to work together, that would be great. And we've had this model working for clinical trials in the past, where two completely different entities, institutions have come up with almost the same kind of idea. We've married them to each other and had them run a very large single trial rather than two smaller trials. So that's worked. I just wonder whether tech startups would be happy working with competitors, though from a global good point of view, that will be the right approach. But if they're willing to do that, we'd be happy to support it.
The second comment I would like to read is from Dr. Harith Chaturvedi, who is an early adopter of AI in oncology in the country. And he shares that we need to nurture internship opportunities for tech community in the hospital ecosystem and vice versa. These could be for periods of 6 months to 2 years. Data sharing could be made mandatory with the necessary guardrails, ensuring privacy and purpose. Tech hackathons in hospital campuses will make partnerships more easy. EMR and data sharing would be made mandatory for PMJ and all panels. This will nudge the culture towards the right direction. Thank you, sir.
Okay. Thank you. Mr. Krishnanga Kalita, would you like to ask a question?
Yeah, hi NCG for organizing this. Actually, my question is actually not a question, but a shout out to Dr. Balaji Ganeshan, who just was looking for some collaborations. So if you are hearing this, you can reach out to me. I'd be very happy to.
Anurag, you're on mute.
Hi, everybody. I think we'll take our questions until 4:30. Mr. Arjun, if you'd like to proceed with your question, please go ahead.
Yeah, hi, thanks for the session. My question, I was unclear about the point which mentions that full-time employees would not be paid from the grant. So we have a open source data collection system and EMR in place, and we are already collaborating with a lot of healthcare institutes. But if there are extensions, additions to be done to support the oncology part, and developers have to work on that, like the developer salaries will not be covered as part of this, is it? Or am I interpreting or understanding it incorrectly?
Would you like to take that up?
Yeah. So, honestly, it's what we are saying is the entire grant cannot be spent on salaries or admin part. But yes, we understand that a data scientist has to work on it, and then certain part is devoted to that. But then you have to have a cap on how much you're, spending on that part versus innovation versus, maybe getting a data properly for your trial and infra, etc. So you divide your overall cost with respect to your plan and the amount you are looking for, and based on that, of course, it would be assessed by us as well. But that's a broader point, that hey, you cannot have entire amount devoted for salaries. There has to be a cap for it.
Sure. Yeah. And so it's about entire amount. That's what I was.
Also, the kind of money that's allocated to salaries should be proportionate to the development that's happening. I mean, this shouldn't be seen as a way of funding employees.
Yeah. Yes. Yes. Understood. Thanks.
We'll be taking one more question and we close. Manoj, would you like to go ahead?
Yeah. Thanks, Anurag. So my question was more around validation, that, most of the time data, and we have had this discussion around the data from the institutes and the problems around it. But usually when you're validating, it is with multiple institutes. It's not with one institute. And it becomes very constrained when each one is looking for some kind of IP sharing. So how do you tackle overall approach where we have experienced this, that sometimes even the data is available on a very deep basis in a particular specialty in an institute, whereas they are discussing, commercial or IP rights for a basic validation work. So unless you match the minds from that level, the data is overvalued in their mind, accordingly.
And I think that's where, a clinical lead and technology lead has to come together with as you said, with a common mind and work together on the problem and the solution, getting the solution implemented. But that has to be solved between these two partners. We can guide as an NCG, we can give a guidance in terms of what can be done in terms of how the data sharing rule should be, and of course it will fall back on respective local as well as ethic committee guidance. But it has to be between two partners, because as an NCG or IndiaAI, we cannot take a responsibility of data being shared and then certain things are not followed while sharing the data.
I would also add to that the value of your solution will be directly proportional to the extent of validation that you do. So, for instance, if you were to come to me and offer a solution which has been validated in 10 very high volume hospitals in India, I would be far more willing to adopt that solution than if it was done in a small nursing home with very little. So I think that's a value judgment that the company needs to make as to how much they are likely to invest in the sharing of the IP with the clinical institutions which offer the data.
No, Dr. Parmesh, what we have experienced that even if you've done in one single high volume setup, still when you go to the second institute, the value they put on their validation is, equivalent or higher. They see my data is still superior. Whereas the cleaning we have to do, a lot of that. This is more in terms of what we have been experiencing. Whereas the time given is not that much by the clinician. So we have to also engage the clinician to validate it. So just more a concern. And, in terms of that, when you partner license free for their patients and other things in terms of supporting the research effort, even some investment is okay. But IP rights is such a complex thing, because how do I go to the next institute? You have to, take care of the community rather than a one HOD level get stuck. So that is all I just wanted to put. I'm sure with your efforts, involvement in NCG, whoever the partners are meshed with, there is a certain kind of a non-commercial approach also to this.
I'll just take a quick comment on that. So I think they're all very valid points. I don't believe the catch grant requires any IP sharing. So the IP can be retained by the companies themselves. With respect to your challenge that even if you've done it in one hospital, the second hospital will still require validation, I think is very valid. And it's perhaps right for that second hospital to ask for validation. It's only when you get to 8, 10 hospitals, then the 11th hospital may not ask for the same level of validation, right? Because then it's in a sense a proven solution. So what you're facing right now, for the first bunch of 3, 4, 5 clients, it's very likely that you're going to have the challenge. And that honestly has nothing to do with this, what we are talking here. It's just part and parcel of what happens in life. That it's a very slow process to get started, and you have to kind of build on that, right? In some ways, yeah. Back to you, Anurag. I know we're running out of time. Yeah.
Thank you.
Thank you so much, Rizwan. As we come to the close of today's session, let's sort of take a moment to thank all of the panelists who've been very patiently answering all the questions. I really sort of deeply grateful from the IndiaAI and NCG team, if I may. Dr. Balu, Dr. Manju, Dr. Vishal, Santosh, Mr. Rizwan, and Professor Pramesh. Really, thank you for being here and helping us, sort of answer questions of the enthusiastic applicants that we are here today with. And on the closing remark, I'd say that Catch is simply not about funding. It is about, sort of building a pipeline, an ecosystem of AI innovators who then gets the opportunity to get stressed in real clinical environments and properly validated for patient safety and scaled responsibly across, India's health system. For innovators and the institutions who are today here, this program will offer both support and accountability and a real chance to build the solutions where, again, you just don't demonstrate promise, but actually drive impact in practice. And we look forward to your applications and evaluating them. And hopefully you are able to shape the future of cancer care in India. Having said that, we would also be providing you with the recording of the link if you would want to revisit it and get some answers to your questions. Besides that, all the queries will be responded that have been sort of addressed to us via the emails, and we'll also be taking note of all of the question and answer that has been asked today here, and we would get back to you with the answers. But do drop us an email with the questions that will be easier for us to coordinate. And thank you, everybody. Thank you for this wonderful session today.